Hi there everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with occluding dead skin in both ears. You can just see there how narrow her ear canals are. And they have to attend on a regular basis. It's an annual removal that they require. And what essentially has happened is our ear canals and the outermost membrane of the eardrum is made up of a layer of skin, and this skin, as it dies and it sheds, it migrates out of the ear sideways, so almost like a conveyor belt. If it didn't, then everyone's ears would be blocked full of dead skin, just like this patient. So unfortunately, in this particular patient, the skin that once used to migrate out of the ear has stopped, and age can be a factor in that. And therefore, what happens is this skin adheres itself to the canal wall, it collects, it oxidizes, and it turns into a browny colour, so it looks actually like wax, but it's not. And you'll see once, as we continue the procedure, the skin that's enveloped and in contact, or nearest to the contact with the ear canal wall, that's fresher dead skin, so it's more paler in appearance, more translucent, if you like, and that skin will die and it will shed and it will be pushed inwards by the fresh layer of skin that's on the ear canal. And as that skin gets pushed further and further in the middle of the ear, it oxidizes and it turns into a darker brown. So you can see this skin here, this is all a bit more of a fresher layer of dead skin, and we're just peeling this off the eardrum, and you can see there's some at the top of the ear canal there, and the skin is also attached itself to the bottom of the ear canal, so that's where I'm going now. I'm just trying to lift this up. Now when you're removing skin like this, the best way to describe what we're doing is imagine you have some sellotape, sticky tape on a piece of paper, and what we're trying to do is peel away this sticky tape, the sellotape, off the paper without damaging the paper, without tearing it. And that's essentially what we're doing. But when you remove skin, it's very stubborn. And it really does stick itself to the canal wall. So you're having to put a lot of force to detach it from the canal wall. And that means with the suction probe going up and down, left and right. You can just about see the eardrum on the right hand side. You can see the blue tinge. So I've just peeled some dead skin off the roof of the ear canal. So I believe now all the skin has detached itself from the eardrum. It's just this layer that's adhered to the bottom of the ear canal. I'm just trying to peel this forward. And in a moment, I'm going to use some forceps, and we're going to use the forceps to grasp onto this dead skin and slowly extract outwards to peel the skin away from the bottom of the ear canal. The patient was suffering from some tinnitus, and it's predominantly in the left ear, and we're hoping it was wax related. So they're going to monitor that for the next few days, and of course, if they're still experiencing tinnitus, especially in one ear, that needs to be further investigated. So the majority of us suffer from tinnitus. So tinnitus, what is tinnitus? So tinnitus is for any sound really. Most people associate tinnitus with being a ringing or whistling sound or buzzing noise in the ear, but it could actually be any noise. But it's any noise that originates from within the ear or the head. So it's not an external sound that you're hearing in the environment. So I'll come back to that in a moment, but I've just removed that dead skin using the forceps, and I'm just using a Jobson horn now just to mop up around the edge. We're not trying to remove every little speck of dead skin or wax, but from under the cartilaginous portion, we can be a bit more liberal here, because the cartilaginous portion, it's not as sensitive as the bony part of the ear canal, slightly flexible. It's got a bit of give and a bit of bounce, so we can apply a bit of pressure on there. So just going back to the tinnitus, so yeah, tinnitus is any sound that originates within the ear or the head. You can also get something called pulsatile tinnitus. So pulsatile tinnitus it's more of a rhythmic beating, a pulse, hence the name pulsatile. Your heartbeat. Sometimes it can be due to, well, you can get what we call occlusion as well. So if you've got a blocked Eustachian tube and your middle ear is blocked, that can also cause a bit of pulsatile tinnitus. But there's other things that can cause pulsatile tinnitus, so that which needs to be investigated. You could have something called a glomus tumour, which is There's tissue growth that extends from the base of the ear canal behind the eardrum. It's normally quite visible and it's got its own pulse. And that pulse hits the back of the eardrum, and hence it makes you can experience a pulsatile tinnitus for that reason. You could have a blocked carotid artery, and that blockage of hearing the blood going through and drips and drabs, and that can be amplified inside your head. So whenever you've got pulsatile tinnitus, it's worthwhile getting that checked. It could just be you're hearing your own heartbeat or pulse because you've got earwax and you've got a middle ear infection. But as I said, it could be other things like a glomus tumour or a blocked carotid artery, so that needs to be investigated. Tinnitus itself, so the more sound type of tinnitus as opposed to a sensation of pulse. Most of us get it now once in a while. I get it from had a long day, which is probably most days when you're a bit tired, but it's short-lived. It's less than a second. But some people get it all the time or most of the time, and there's again many causes of tinnitus. There's too many to go through, but there's a big link between hearing loss and tinnitus. So a lot of my hearing aid clients, they also suffer from tinnitus. If I'm asking for a percentage, probably about 30%, 1 in 3, I would say. It's quite an arbitrary guess that. I'll have to look at the figures on that actually, but top of my head, I would say 1 in 3 do suffer some form of tinnitus. So there's a big link between tinnitus and hearing loss. But whenever you've got tinnitus worse in one ear, or it's more predominant in one ear, or it's only in one ear, again, that would need to be checked. Now, again, it could be something just like earwax or middle ear infection, but there can be other conditions like Meniere's disease, which can cause vertigo as well in the ear, a sensation of pressure, fullness, and fluctuating hearing loss, normally at the lower frequencies, and of course tinnitus. The tinnitus, the fluctuation in hearing and the pressure sensation normally exacerbates before attack of vertigo, so that's called Meniere's disease. So I'll just come back to that in a moment. So you can see we've removed a lot of the skin already, some fresher skin. You can see how transparent this skin is compared to the other skin I removed. That was more on the core, the older skin. Sometimes you can have a condition called a vestibular schwannoma, also known as acoustic neuroma. That's a soft tissue growth that actually originates, and it's benign and it's non-cancerous. It originates on the balance nerve. Now the balance nerve and the auditory nerve are actually intertwined, and this vestibular schwannoma or acoustic neuroma, it's very rare, but if you do have that, I believe it's 1 in 10 that actually grow, and it can impinge against the hearing nerve, the auditory nerve, and that can cause normally a high frequency hearing loss in one ear, but also tinnitus in that ear. So again, that needs to be investigated. An MRI scan typically is performed and a hearing test just to rule out that is the case. Now this patient, this patient also suffers from eustachian tube dysfunction. So eustachian tube dysfunction is the eustachian tube, which is an orifice that connects the middle ear, which is a cavity behind the eardrum, which should be full of air, to the back of the nose, the nasopharynx. We want the air pressure behind the eardrum to be the same as the air pressure in the ear canal and the atmosphere that surrounds us. And the eustachian tube is normally shut at the back of the nose. During brief moments in the course of the day of swallowing, yawning or chewing, that eustachian tube contracts as muscle either side near the back of the nose, and it opens up momentarily and the air pressure can equalise itself. And when the air pressure is equal either side of the eardrum, that's when we hear the best. But if that eustachian tube is blocked at the back of the nose, either due to congestion or the muscles don't contract, or you're just born with a narrow eustachian tube, there's no air left in the middle ear. All the remaining air behind the eardrum is sucked in, it's absorbed by the neighbouring cells. That creates a vacuum effect. The eardrum gets sucked in like you're on a plane, and then that causes fluid to ooze out of the cells in the middle ear and collect within the middle ear, and that can then go into glue ear. So this patient hasn't got glue ear, but they have got eustachian tube dysfunction, but primarily on the right side, and you can see the top part of the eardrum there where there's a bit of skin, there's an attic retraction. Where I'm focusing now, just at the top, so you'll see the hammer bone, which is the middle bone, the malleus, and at the top of the hammer bone is a little pointed ball end. Just on top of that, you can see there's a bit of skin there. I removed the majority of it. And that's the attic retraction. You can see where I'm going now with the sucker actually. Just to the left of that, that's the attic. And that part of the eardrum sucked in because they've got a blocked eustachian tube. But on the left side, which is the ear that experiencing more tinnitus in, they don't have a blocked gestation tube. And now, the thing with the blocked gestation tube, it can be intermittent. In half an hour, the patient can go home and it can resurface itself. So it may just be Sod's Law right now, or during the appointment, it wasn't there. We did test for it on the left side and the right side, and they have got a history of that, and they know the treatments. We've previously given them treatments. So we cleaned the ear, I cleaned the attic, so there's no skin in there. You can hear a lot better. I'm just using a Jobson horn now, just to mop up at the entrance of the ear canal, and you can just see how narrow this patient's ear is. It's really narrow. And you can see the skin's quite mushy as well near the entrance. And that's a nice view of the eardrum. We've got all that skin out in the attic. Yeah, there's a few flakes of skin here, a few flakes of skin there. You can be here there all day removing it, and sometimes that skin can cloud up. We've got to be careful, it can be quite noisy. And some of that, all this skin here, it's all fresher layer of skin, or deeper in the ear anyway, and it's not ready to be removed really. You can pull it all down. You can cause more problems. You can cause irritation, abrasion, infection because of that. That's all the skin, so these sheets of dead skin. See, some of them are quite large. I forgot to put the pencil as by means of comparison. It's just very busy today. I hardly have time to do much today, truth be told, other than just to treat the patients and get the clinical notes down, wipe down, and get ready for the next one. Well, I hope you enjoyed that video, guys, and you're keeping well and safe. Remember, be nice and be kind to each other. Thank you. Bye.